welcome to everybody who's joining the webinar. This is new to me, doing a webinar, so please bear with me as well. I'm going to do a brief overview of nicotine dependence and treatment. Obviously, there's a lot more that could be said about this, but this will at least be an introduction. One of the amazing things about treating tobacco dependence is we have fantastic medicines that are available. They've been available for quite a length of time now, and we know that they work, and we should really try to offer them to people that are in need of them, who are addicted to tobacco and tobacco products. I think by starting off looking at nicotine itself, which often raises a lot of emotional responses in people, and we want to be clear about what nicotine is and what it isn't. Nicotine itself, and particularly I want to talk about nicotine replacement. It's important to distinguish that nicotine itself is not a carcinogen, as opposed to tobacco, which many of the products within tobacco, many of the chemicals within tobacco, highly carcinogenic, and that leads to the multiple medical problems that people have. Nicotine itself is very addictive when inhaled or delivered by tobacco, which is a really important distinction to make for people when they're looking at alternative means of providing nicotine replacement, which don't have the addictive quality that inhalation or delivering by tobacco does. So we'll talk about cigarettes and how it delivers nicotine in such a potently addictive way. It's going to be approximately 1 milligram per cigarette is what gets delivered. If people smoke more intensely or longer, they can deliver a couple of milligrams per cigarette, very rapidly going to the brain with an addictive potential, very similar to cocaine, heroin, and other very addictive substances. Part of why this high addiction level is because of how it's delivered. It goes directly from the lungs to the heart, straight to the brain. This is even faster than injecting something. We think about IV use of substances as being very, very fast, but smoking something or inhaling it is even faster. So on this diagram, you can see that inhaling something goes directly from the lungs to the heart to the brain, giving this very large stimulation to the brain, and this is responsible for the very, very high addictive quality. If it goes through what we'll see later in a slide where it's going through transdermal or submucosal or other absorption, or even if you inject it into the vein, it would have more steps. It would have to go from the vein to the heart, back to the lungs, back to the heart, and then to the brain. And all of these additional steps slow down the addictive quality. Things that get delivered to the brain more rapidly are far more addictive. When tobacco gets to the brain in this very rapid way, it stimulates dopamine in the brain's reward center. These are the deepest parts of the brain. These are very, very similar ways in which things like heroin, cocaine, and other highly addictive substances create pleasurable sensations within the brain, as well as leading to the addictive behaviors associated with tobacco. We have these wonderful medications that can really help people. We've had about 10 years of experience after the publication of Treating Tobacco Use and Dependence, where we really know that we can treat virtually all tobacco users and all people who are addicted. There are some specific populations listed for which there's insufficient evidence. That doesn't mean that they shouldn't be treated. It just means that we're still looking for more evidence to treat them. I treat everybody on the list as best I can. The medications we've got available for tobacco dependence, these are the 7 FDA-approved medications that we've got. On the left-hand side of the slide, you'll see over-the-counter medications such as nicotine patch, gum, and lozenge. These can also be prescribed, and insurance can cover those, but people can also purchase them over the counter. On the right-hand side of the slide, you'll see the prescription-only medications such as the nicotine inhaler, nasal spray, bupropion, which is also known as Zyban or Wellbutrin, and varenicline or Chantix. When we talk about how we're going to consider what medication to use with someone, Obviously, we want to pay attention to a patient's preference and their previous experiences. If someone's had a great experience with a medication, they've been able to utilize a medicine in a way that's helped them, we want to pay attention to that and use it again if at all possible. If someone's had a negative experience with a medication, we want to talk to them more about what that was like. Is it because of the medication itself or some interaction with their own personal body, or is it something that they could be educated about to do differently and have a different experience with it? Oftentimes, patients themselves will have certain characteristics that might lean more towards certain types of medicine than others. If they've got a history of depression, or we can use medicines that treat both depression and help with the tobacco addiction. If they're concerned about weight gain, there's certain medicines that can delay that, as well as their own lifestyle choices and what's going to work the best for them. As clinicians, our familiarity with the medications is going to greatly affect which ones we choose, and I encourage you to try as many as possible so you get familiar with them and have your own experiences to build on, so that you will have more options to offer people when they ask for them, and more experiences of how people are able to actually use them in real life. There are occasionally contraindications for selected patients, and those are important to pay attention to, but relatively few. Nicotine replacement is the giving of the actual nicotine itself in a patch. We can provide anywhere from small amounts, such as 7 milligrams, all the way up to multiple patches that I will use with people if needed. Nicotine gum and lozenge come in 2 and 4 milligram sizes. Nicotine inhaler and nicotine nasal spray are also ways of delivering nicotine to the body. And with each one of these, or combinations of these, we can see a consistent doubling of the abstinence rate very safely, very effectively, and we can use them for as long as we need to, 4 to 12 weeks or longer, and I often use it longer. Nicotine replacement therapy has great advantages, one of which is relieving withdrawal symptoms, reducing cravings, and delivering nicotine without the toxins from tobacco. One of the aspects of helping to make people a little bit more comfortable is that it allows them the time and space to actually focus on changing their behavior. Addictions have both a physiological and behavior component, and they're best treated with both a physiological treatment with medications as well as the behavioral change component, which is going to be the primary way in which we can unhijack the brain from the chemical and then remodel the brain in a way by changing behavior and by modifying people's behavior where they identify more clearly as a non-smoker or non-user of tobacco. Nicotine withdrawal is interesting because a lot of times my patients will say that they don't experience withdrawal from nicotine. They experience withdrawal from cocaine or heroin or alcohol, but they don't often identify necessarily with the specific symptoms of withdrawal. They identify with irritability, anger, the specific symptoms themselves, but they often will feel like they can handle it on their own or don't want to use a medication to help with it, despite the fact that we know that medications can greatly reduce these symptoms. Even though the symptoms only last for a few weeks and are most intense in the first few days, these are things that we can help with to make people more comfortable from day one and help them address the other important aspects of their dependence on the tobacco. So when people tell me that they don't want a medicine for nicotine withdrawal, sometimes I just try to reframe things in terms of what nicotine replacement can do, some of the benefits, and most of these things are things that just about anyone would prefer. They'd like decreased irritability, decreased anxiety, improved concentration, improved mood, and decreased cravings. So these are some of the things that can happen from day one. As soon as someone starts taking nicotine replacement, it can be offered quickly, easily, and greatly reduce a lot of the discomfort associated with nicotine withdrawal and help people to feel a lot better about continuing their treatment. Addressing concerns about nicotine is an important part about things because people may have concerns about the safety of nicotine replacement. There's no evidence of increased cardiac risk. This was a common concern over time and continues to be. So I talk to people about the cardiac risks involved with tobacco, but not the evidence of increased risk with nicotine replacement. People are worried about cancer. Obviously, the cancer risk associated with tobacco are very high, but there's no evidence of nicotine replacement causing cancer. Ineffectiveness of nicotine replacement is a very, very big concern. This is often because in the past people have not received an adequate dose. So they say that the patch didn't work for them or the gum didn't work. It's usually because they weren't receiving enough nicotine replacement. If someone is getting at least 1 milligram or 2 from each cigarette and they're smoking a pack or 2 a day, they might be getting 20, 40 or more milligrams of nicotine each day from their tobacco. If we give them a 7 or 14 or even 21 milligram patch, that can be grossly inadequate, and they might say it didn't work, mostly because they weren't getting enough nicotine replacement. If they're afraid of what happens if I get too much nicotine, it's important to go over any symptoms of getting too much nicotine, such as nausea, dizziness, headache, which can be relieved by reducing their dose. So we want to make sure that we can maximize the amount of nicotine replacement we can give somebody and let them know that they can be in control of how much nicotine they're receiving, as well as feeling much more comfortable than they might have previously when they received an inadequate dose. Fear of addiction is a fear of some patients. And again, we can reassure of the low addictive potential due to the delivery system. When we look at the slide again, comparing to the previous slide where it went straight from inhaled nicotine, lungs, heart, brain, this is a much, much slower way of absorption, whether it's under the tongue or submucosally, whether it's transdermally. It takes a while for that to absorb into the system, eventually get to the veins. From the veins, it's going to go to the heart, then to the lungs, then back to the heart, then back to the brain. By the time it does, the little spot in the brain is much, much, much less intense. This leads to the non-addictive qualities of nicotine replacement relative to the addictive qualities of inhaled nicotine. Withdrawal symptoms over time, again, these are things that in the first few weeks are most intense: impatience, irritability, anxiety, and hunger. And in the pink line, you can see the non-medicated or sort of cold turkey approach toward getting off of tobacco. There's a fair amount of these symptoms early on, and that often leads people to go back to using tobacco. If we provide nicotine replacement right away, we can relieve all of those symptoms from the very beginning with them. Each of these medications can be very, very helpful. So we'll start with nicotine patch, having different dosage sizes, 7, 14, and 21 milligrams each patch. This is the maximum amount of nicotine it's going to provide. So if someone doesn't use it the full 24 hours, they're going to receive less. And we try to get people to use a new patch each day, where they put a patch on, leave it there till the following morning, take the old one off, put a new one on a different spot. You can put it on any part of the skin that's available to them. Most people prefer on their arm where they can keep track of it, but you can really put it anywhere where they're going to be able to reduce irritation and be able to keep track of the medicine itself. It's gradually released so that people have a very steady state level of nicotine replacement, but it's often underdosed because people don't realize that they need a lot more nicotine when they're replacing the amount that they're receiving from tobacco. They receive some itching and tingling in the first hour, but this resolves pretty quickly. And oftentimes when I'm with somebody and can watch them apply the patch and see if they get any initial irritation, by the time our conversation's done, usually the itching and tingling is gone. Sometimes people get vivid dreams or sleep disturbances, but more often they don't. So I encourage people to wear it for the full 24 hours. If they do get some vivid dreams, I talk to them about their vivid dreams and ask whether they bother them or not. And oftentimes the vivid dreams don't bother them and they still wear it. Occasionally there's sleep disturbances or nightmares where people need to take off the patch at nighttime so that they can get better sleep. The localized skin reactions are caused by the adhesive most commonly. They occur frequently, about half of patients, but really only about 5% will discontinue due to this reaction. A lot of times it's because they're not rotating the site, so we encourage that and provide hydrocortisone as a way of relieving that as well. So nicotine patches can provide very consistent nicotine levels. They're easy to use, once-a-day dosing. However, there's not the inner part of the day titrating that you can do with some of the other medicines, and it's often underdosed. So when we look at some of the other medicines that we can titrate as throughout the day at different levels, we look at faster release things like nicotine gum, which comes in a 2 and 4 milligram size. This is used differently than regular gum in the sense that you chew it for a second or two, releases some peppery taste in your mouth, and then you park it in the side to allow for absorption of the nicotine. It's absorbed much better in a non-acidic environment. So we talk about people avoiding acidic things like coffee, juice, and soft drinks, and using enough pieces each day to provide adequate nicotine replacement. The advantages are around satisfying some oral cravings, delaying weight gain, allowing people to actively manage their nicotine replacement throughout the day. But it may be problematic for some people with dentures or other dental problems, and sometimes people don't take enough of it, again, often underdosed. Nicotine lozenges, very similar to the nicotine gum in the sense of it's both 2 and 4 milligram sizes. These you don't have to chew, you just put them in and allow them to dissolve slowly. Again, avoiding acidic beverages and using enough during the day is very important. Nicotine lozenges are easy to use, they're easy to take throughout the day, but again, are often underdosed. A nicotine inhaler is a bit of a misnomer. It's more of a puffer than an inhaler. You don't inhale it into your lungs. When you puff on the inhaler, it's a small white plastic device with a little cartridge that contains about 4 milligrams of nicotine per cartridge. People puff on it. The nicotine goes into the oral mucosa and gets absorbed in the oral mucosa, similar to the nicotine gum and nicotine lozenge. You usually have to use a number of these cartridges per day. And again, eating or drinking can decrease the absorption and should be avoided. And there's decreased delivery at cold temperatures like Rochester, so paying attention to trying to keep them at closer to room temperature allows them to work better and provide more nicotine. The advantages are people really like that little white plastic container. It's a hand-mouth ritual. Even if they just use the plain plastic container, that's okay with me. Give them something to use their hands with. But there can be some throat or mouth irritation from the nicotine itself. And sometimes people aren't aware of the temperatures that they have to keep them at near room temperature to work most effectively. Nicotine nasal spray is another alternative for people. This is very rapidly absorbed nicotine, more so than the other ones, but it's fairly intense for people when they use it. It's something that you give a spray to each nostril, and it's absorbed directly through the nasal mucosa. Each spray is about 1 milligram each, and as I said, it can cause some nasal and throat irritation, so that for some people it's bothersome and they don't always like the side effects from the nicotine nasal spray. However, it does provide a very rapid release of nicotine. Bupropion is one of the antidepressants we use with depression and other mental illnesses. It's labeled under Wellbutrin. It's also labeled as Zyban for tobacco cessation. It affects norepinephrine and dopamine in those reward pathways that we talked about earlier. It's capable of doubling abstinence rates for tobacco. Usually people begin it a week or two before and continue it for up to 6 months or longer if it's working and helping them. It's easy to use. It delays weight gain. It does increase seizure risk slightly, and we have to be careful with people with a history of seizures or eating disorders or other ways in which their seizure risk might be increased. Varenicline is our newest medicine. It's been around for 10 years or so, but It's a partial agonist at the nicotinic acetylcholine receptor and can more than double the abstinence rate. People use this highly effectively to address their smoking because you can start it while you're still smoking. You take it in small amounts, it builds up in your system. It helps people to cut out their smoking entirely. You start with one small one a day, then one small one twice a day, and then one larger one, 1 milligram twice a day. It does cause some nausea, so for people to take after eating and with a full glass of water is very important, and can be used for up to 6 months as a maintenance medication. Sometimes people get abnormal dreams or insomnia with it as well. We have to pay attention to it in patients with severe kidney disease, which is rare for most people. And with every medicine, I pay attention to people's mood and behavior and how it might affect them in terms of drowsiness or other feelings. Tobacco smoke interactions with medicines are really, really important. To differentiate from nicotine replacement, which is not involving smoke, the combustion products of tobacco will actually create certain enzymes in the liver, so that the tobacco smoke will actually create more of these P450 isoenzymes, and these are very important enzymes in the metabolisms of certain medications that can result in a reduced pharmacological response, which means that people have to be on higher doses of certain medicines. So some of the medicines can be a lot of the psychiatric medicines like Clozaril or Zyprexa or Luvox, as well as a non-prescription, caffeine being a very important one, where when people are actually getting tobacco smoke, they require much higher levels and are affected less by these substances. When they stop tobacco smoke, even if they're using nicotine replacement at very high levels, the enzymes change in their body and these medications become twice as strong. So when we talk about something like caffeine, is one of the ones I paid a lot of attention to with people who are addressing their tobacco, because a majority of it's metabolized by this enzyme that we talked about. So when someone is smoking with tobacco smoke, they're going to have a lot more of this enzyme, and they're going to feel less effect from each amount of caffeine. When they quit smoking, even if they're using large amounts of nicotine replacement, they've got to address their caffeine intake in coffee, teas, sodas, anything they're getting caffeine from, and I generally advise them to reduce it by 1/2 so that they don't get too much caffeine, and the caffeine toxicity can often mimic nicotine withdrawal, so people feel like they need a cigarette instead of just realizing that it's actually the caffeine that's building up in their system that's causing them to feel anxious or irritable. Weight gain concerns are something that most everyone is aware of. So it's often a barrier for people who are addressing tobacco and afraid to address tobacco. We can help it with nicotine replacement, in particular nicotine gum and lozenges at the higher dosages, as well as bupropion will help delay this weight gain and allow people to increase their activity, which usually happens as people address their tobacco. Foods taste better, so people eat more food, but they also increase their activity level, feel a lot better, gain confidence, and usually can regulate weight much better over time. We talk about highly dependent smokers. These are people who, again, smoking a pack or 2 packs a day and might be underdosed with nicotine replacement. So we want to offer people enough nicotine replacement, higher doses of nicotine replacement, and combinations of nicotine replacement. Combinations include things like using a longer acting formulation like the nicotine patch, which can provide a constant level of nicotine, plus an additional short acting form of nicotine, such as gum, inhaler, nasal spray, or lozenge. And these can be used together to really give people enough nicotine replacement so they get enough without feeling overdosed. Bupropion and nicotine patch can be added together. And the people that I'm working with, who are looking at a lot of co-occurring addiction and mental illness with tobacco dependence treatment, the majority of people express an interest in stopping tobacco use. just as often as people without addiction or mental illness, and they can quit just as successfully with higher levels of care. They often need more frequent, more intense treatment. So for our general things, more is better, more intensive treatment, more intensive medications, increased dosages and combinations, and longer durations. We want to involve more than one type of provider and provide lots of support. Even patients who aren't ready to quit will often benefit from nicotine replacement. It more than doubles people's chances to be abstinent at 12 months. Even if people are unwilling to make a full quit attempt, they learn more about how the medications work, and they're able to use it in future quit attempts. So clinicians should encourage the use of effective medications. We have effective medications that can double people's abstinence. Combinations of medications are very helpful. Higher doses and longer durations often help people. Most people are underdosed with their nicotine replacement. Offer nicotine early and often, even before someone's entirely ready to quit. They can learn about the medications and utilize them to see how they're going to affect their bodies and be able to utilize them more effectively at future quit dates. And most importantly, treating both the physiological and behavioral components together. We can treat the physiological ones with medications. The behavioral ones lead to people's ultimate recovery from tobacco. Questions?